On this episode of Back and Brew, I'm so excited to have the guest, Dr. Sharad Rajpal. He is a neurosurgeon who has a complex spine background, but has served the Boulder community for over a decade. This episode has a lot of value for a new spine surgeon coming out of training and into practice, looking to launch a successful spine career. This is Back and Brew. Yeah, man. Thanks for coming on. I've known about you for a long time.
Yeah, likewise. I've heard your name.
And it's always funny. Like, we've both been in the Denver market for over a decade.
Yeah.
But just never crossed paths, which that's what I love about this community, man, is that, the people that seem to stay the longest, I'm always really interested. I'm like, what did you do?
Why are you still here? Who are you?
Yeah. So yeah, tell me. So first off, tell me this is Back and Brew. Tell me about what you brought.
Well, it's difficult to find something that's unique. I mean, I had a lot of guests on with a lot of different, teas and whiskeys and coffees and stuff like that. So, I work up in Boulder, Colorado. So, my wife actually put herself through college working as a barista. So I call her a coffee snob. She may not appreciate that, but she loves Ozo coffee. I think their model is pretty good. It's probably, if we were to talk about it, maybe how I like to perform surgery as well. They're all about sustainability. It's all about the community, good quality. So they kind of give back to the community. They really sort of give back to the people that grow their beans. They have all these programs where you can bring in your own cups to reduce waste and all that kind of stuff. So I think conceptually it's a great model. And I think that their coffee is really good. I call it kind of a little bit of heaven in a cup. So it's good. So I'm sure you've had Ozo. They've got several offices around.
Yeah, I went to school in Boulder. So like
Ozo,
yeah,
okay.
I went to see you.
Okay.
Ozo was a staple for me. Like I loved it.
Yeah.
Quick way to get coffee. And it was interesting. Like I looked up because a big part about this podcast I love is that I get to actually research a lot of the brands that I've consumed in some point in time.
Yeah.
And it was interesting to see that theirs was legitimately built around sustainability and giving back to the bean farmers in some type of way that was somewhat equitable. Obviously, it's not going to be completely equitable because the beans now are worth so much more than the beans when they first get them.
That's fair.
But it was cool too because it was started by someone locally who their biggest thing is I like good coffee and I want to be a good person. Exactly. And like that's what it started on.
Yeah.
Yeah, man, I love coffee. Ozo is one of my favorites. So yeah, thanks for bringing it on, man.
Yeah.
Cheers.
And you went straight up black coffee, and I'm definitely like a latte, sugary kind of guy. So I apologize for the people that are purists out there.
Is that where the division with you and your wife goes in the?
Oh yeah, she's like you, like don't no cream, no sugar.
Yeah,
and I'm
same.
Like, you gotta load this thing up with all the goodies, lighten it up.
I've seen it kind of online. Your wife's pretty active in Boulder too. It seems like.
She is. She's actually the president of the school board in Boulder Valley right now. So she's done it for 4 years. She's up for re-election. This is not a campaign video or anything like that, but she doesn't have anybody running against her. But yeah, she's been kind of involved with that for several years. A lot of volunteer work, which is great.
It's funny. There's I have kids that are young, and we are in the decision making process of where they go to school and everything. Yeah. And there were really 3 school districts that we looked at that were really good school districts. Boulder Valley was one of the best.
Yeah.
Douglas County, and then Cherry Creek.
Yeah. We know them well. Yeah.
Yeah, we live in obviously South Denver, so it would have been hard to go to Boulder Valley at that point. Yeah. But my wife grew up in Longmont in Boulder.
Oh, okay. Oh, wow.
Yeah, my in-laws, their house burned down in the Marshall Fire.
Oh, I'm sorry about that. Yeah, awful.
Yeah, I mean, not everyone, but thankfully, and as bad as is a weird way to say this, the Marshall Fire at least wasn't somewhere where people couldn't rebuild,
Yeah.
For the most part.
Yeah.
But yeah, it was crazy. It was, it was wild.
Wow.
My in-laws and their 4 dogs took over our basement.
Oh my gosh. For a long time. Had they rebuilt their house?
Yeah, it was crazy though. The Boulder County is one of the hardest places to build anything. And the red tape was wild. And this will actually probably kind of speak to the insurance part. I'm sure we'll talk about in healthcare.
Yeah.
But insurance, they had a house that was about 3,500 square feet on 3 acres, and it overlooks the Flatirons. So like beautiful, right?
Yeah.
It was built in the 60s, and for them to what they got from insurance was so laughable. Yeah. It wouldn't even cover a third of what it would cost to even build something similar to that.
Yep.
Then not only that, so they're going to have to front, a stupid amount of money to be able to rebuild.
Yeah.
But the regulations in Boulder for building was obscene.
Yeah.
What they had to do,
Yeah.
and it was like totally nonsensical. Totally like
Yeah.
they went through so many hoops. And my father is a home builder, or
Oh, wow.
my father-in-law was a home builder
Oh,
too. So
wow.
he like
He
had his
knew.
own crew,
He
and he's
knew.
like,
Yeah.
I don't know how other people build.
Yeah.
But yeah, they got it rebuilt. I think they moved in like a couple weeks ago. So that's how
Oh,
long it
that's
took.
great. Oh,
Yeah.
you're relieved as much as they are, probably.
No, he had other houses and rental
Yeah.
properties. So he was living in they were
Okay.
living in another one. But yeah, it was just crazy I just remember it being windy that day, and then, you know,
Yeah. Neighborhood's
15
gone.
hours later they were in my basement.
Yeah. Thankfully, they were okay and everybody was
Ah,
okay.
yeah.
Yeah. Yeah.
Yeah.
Except those few people, but yeah.
Yeah. So tell me, what brought you to Boulder?
Yeah, so we actually didn't have any real ties to Boulder, to be totally honest. I grew up in Wisconsin, Madison, Wisconsin. My wife is from Minnesota, and I think when you go through your training, medical school, residency, fellowship, all these things are really dictated for you to a degree. You can pick your medical school, but when you do your match for what you're going to go into for neurosurgery, you're a little bit at sort of where are things going to fly in the wind and land. So I was always promising myself. I grew up in the Midwest. I do not love winter. I do not love those things. I'm Indian. Technically love warm weather.
We're both tropical. I get it.
Yeah, we're tropical. That's probably the good word for it. So I think that when I was growing up all my life, I just always hated winter, even though I appreciate where we grew up. And finally, we had the opportunity to sort of decide, okay, on the map, where do we want to go? And so we really sort of were looking at places along the coast, places that were warm. Boulder, Colorado came up as an opportunity. It's not an opportunity that comes up often. So a job opportunity came up. My uncle actually lived in Denver at the time, and my grandmother did. So we came out here and checked it out, and we never looked back. So I think we just got very lucky. It was, I think life is sometimes, it'll throw you things that you should probably just open the door. Opportunity knocks. So go ahead and take it. So it worked out well.
Uh, It's interesting. Like, we work with a lot of new surgeons that are right out of training,
Yeah.
and there's so many of them that move to where they want to live ultimately for their first job.
Yeah.
And very, very, very few of them get to stay in that same place. I
Yeah.
mean, even in Denver, you look at most people that move to Denver, the statistic that we had was 70% of surgeons, spine surgeons that move to Denver
That's
within
crazy.
their first 2 years fail and have to leave the state, not just switch practices,
Yeah.
leave the state.
Yeah.
So it's awesome that you were able to do that. And it's not like you did this 30 years ago.
Yeah.
Like, Boulder was still cool. Denver was
Yeah.
still cool. Colorado was still cool when you did it.
Yeah.
Um, what do you like attribute some of the staying power, your integration into the community, and building a successful private practice?
Yeah, I think that, I had this, so I go back and give this lecture to a lot of residents and fellows too. When you're looking for a job, I think the problem is that usually the number one thing that people look at is what's my salary going to be? What am I going to make? Because everybody's money hungry when you finish your medical school and residency. I mean, you're so broke and so destitute and desperate for anything. You look at the dollar signs. I think if you look at the top three things, and we sort of went through this, what number one for us was, where does your family want to be? Obviously, if you're a single person, it doesn't really matter because you can do whatever you want. But it was a collective decision between my wife and I. We looked at schools. We both grew up in public school system, so that was really important to us. Where they had a go school system. You were just talking about Boulder Valley; it's got a fantastic public school system, and then obviously partnership with the guys that you're going to be, or the people you're going to be working with in your job. You have to get the good vibe. It was definitely not easy. Money was not number one. It was all about, good place to raise a family was the first thing. It was a beatdown for the first couple of years. I'm not going to say it wasn't. I took every other day call. We were covering 5 hospitals in the county. So it was, a decision that my wife and I made that said, hey, I'm going to be working for the first couple of years, just trying to establish myself. It was not easy. It's the typical story everybody talks about, just put your head down at work all the time. And so we decided that's how we were going to do it. And kind of made it work for 5-6 years, and just kind of, we'll talk about what happened. There were a little bit of consequences to that later on, but kind of was the yes man for everything. Every surgery that came in, I took it. My wife was very understanding, very supportive. And I think just, I had good partners as well as a good business model in Boulder. And I think I just happened to land in a good place. So it worked out.
Yeah. How do you identify Boulder as being like a good market to start in, right? So like a
Yeah.
lot of people, if someone was going to move to Boulder right now and try to
Yeah.
start it, it'd be fairly difficult,
Very
right?
difficult. Yeah. Yeah.
How did you see that as like,
Yeah.
Boulder, this is a beautiful place. It's going to be up and coming.
Yeah.
I can grow something from here.
We didn't know that, actually. I think that we didn't know how difficult it was. We didn't really know a lot about Boulder at the time, to be totally honest. We kind of landed there by accident. But I think, when we came and interviewed, I had talked to the senior partners at that time, and I talked to actually the spouses to see how things were, because sometimes you get one story from the surgeons, you get another from the family members, right? You go out to dinner, everybody's all buttoned up and tight, and everything looks great from the surface, and then I think you get the real story from the spouses, from the family, like, hey, you really see your spouse? Is it really a family friendly program? Are they never here? I think they give you the real story. And so I kind of did a lot of research in the back. And I think that's really important. And again, Boulder is not a place where you can just hang a shingle and survive. We were actually the only neurosurgical group north of Denver, between Fort Collins, Greeley, and then Denver. As you know, you've been here for a long time. That was a premier group at that time. And I don't think life is a lot about, I think there's a lot about luck and opportunity that came. So I'm fortunate that I was able to get a job there.
Yeah. Again, it's funny because you guys, the BNA was kind of
Yeah.
like had that northern Colorado corridor, or at least
Yeah.
Boulder
Yeah.
area locked down, and did great work there.
Yeah.
Um, everything, kind of from the going from MIS to even integrating robotics and things like that,
Yeah.
which I definitely want to talk to you about later and kind of better understand.
Yeah.
Um, so you get to Boulder, you you kind of hang your shingle. How developed was BNA at that point? Boulder Neurosurgical
Associates.
Associates.
Yeah.
Yeah.
Yep. Yep.
How
Yep.
how well established
Yeah.
was it when you arrived?
So, actually, what happened was the situation was BNA had been around for quite some time, but I think it really developed under Jeff Trayman. I don't know if you probably heard his name. He had come out of the barrel. He kind of really started the group with Dr. Villavicencio. And actually, Dr. Trayman was actually leaving. That was the spot that I was coming in to take. He's the one who had written a letter of interest for people like, hey, there's an opportunity there. They had brought in a stereotactic radiosurgery system. They had brought in intraoperative MRI. So he was very forward thinking with regards to practice, I think, which is also kind of leads to why they were so successful. He partnered with the hospital, so he was a very business minded individual. And so I think, we talked about earlier how you can do it alone, or you can kind of do it as partnership, or you can be sort of on the cutting edge. And he, I think, had the foresight to say, okay, we're going to bring in the first intraoperative MRI scan in the area. We're going to team up with, stereotactic radiosurgery. We're going to do all these partnerships, and we're going to cover the hospitals. They had kind of a lockdown with all the hospitals with trauma coverage. So you kind of develop this, sweeping wide net around the county is what they kind of did. And so they did good surgery. When I came in, I think they're named as like one of the top neurosurgery programs in the Denver metro area. I just remember that that's kind of what they were advertising when I came in. So I can't take credit for any of that stuff. But when you come in and you see that that's kind of the nomenclature and metrics that they have, it's all great stuff. You're like, hey, these are forward-thinking people, and I'm all about forward-thinking technology, cutting-edge stuff. And I think if you sort of guy have to talk or walk to walk, and I think they were walking the walk at that time. So you could look around, you're like, this is a great fantastic practice. They had older people, and I think that's important for success as well, right? You always want to have partners that you can bounce stuff off of. I was going to be a new partner, new guy, so I think that it kind of had all the elements that were great. Their spouses talked, good things about the practice as well. Again, like I mentioned, so you got to find out like what's the real deal here.
It's interesting whenever we're making a hire, even especially as a spine rep, we definitely try to get as much understanding of the home life as possible.
Yeah,
Because the support system is wildly important.
yeah,
My wife will be the first to tell anyone that's interviewing with us, hey, you're going to miss some stuff you're not going to want to miss
yeah,
while you get this started. Like
yeah,
you are going to miss important dates and things that honestly, and sometimes you probably shouldn't miss.
yeah.
Um, but that's just kind of the nature of the beast now.
It is.
So kind of tell me about your evolution as a surgeon from
Yeah,
then to now. We had talked about it briefly
yeah,
before you popped on of you know, I kind of said from a rep standpoint, I'd see these young guys come in and they're like, I'm 100% MIS. I'm gonna do all MIS.
yeah,
And then for a couple years they do that. And then they're like, oh wait, man, I'm starting to see some pseudos. Maybe I
yeah,
don't have the access to the disc space that I really want that I would get with open or mini open.
yeah.
And so it's been really cool as a rep to see these surgeons evolve. Tell me about your evolution.
I think the most important thing for success for new surgeons is a lot of adaptability, and I think we do so much training and understanding, right? So neurosurgery is a 7-year training, and then I went and did a 1-year fellowship, and I'm very grateful for the experience I had. I worked with orthopedic and neurosurgeon. So we never got orthopedic, exposure during our training. So it's always nice to sort of, hey, wait, these guys are actually teaching us something different, ways to look at it differently from a neurosurgeon. So when I came into practice, I think the most important thing is using sort of the tools you have in your chest to do things the right way. I was taking sort of copious notes in the end of my residency and during my fellowship of like things I wanted to do and not do. So you kind of take elements almost like the Frankenstein and say, okay, I like these elements of MIS or not so much. I like these elements of technology. Here's who I want to be when I go out and practice. When you're green, I mean, you don't have a lot of confidence because you have to make the decisions. We were talking about this earlier, how it's like, hey, like you got to put your big boy pants on now, and you got to make all the decisions. Nobody's going to be holding your hands here to help you decide. You can always reach out for help, but you have to really sort of gain that confidence. But you have to be able to do things that you have learned to do and do it well, right? I mean, they always say, one successful patient gets you 10 referrals. One terrible patient will take out 100 patients in terms of reviews. I mean, you have to do good work right away, which is the most important thing. So I think adaptability for me was the most important thing, and I was always willing to do whatever my partners didn't want to do. So with my fellowship training, I was doing simple surgery, I was doing complex surgery, I was doing deformity surgery, whatever they wanted to throw at me, I never said no. And went through all the risks and complications with the patients. But I think the other thing was talking to the administration about really getting cutting edge technology for me was really important.
So tell me a little about the cutting edge technology, because you talked about the fact that the previous partner had already brought in
Yeah.
intra-op MRI, um, as well as some of the stereotactic technologies.
Yeah.
How does technology fit into your practice? How has technology evolved in your practice? Kind
Yeah.
of kind of bring that back.
It's great. So it's fascinating because I can just give you a brief story. Navigation is one sort of technology, as you know, that helps us stereotactic navigation. Or you can place a screw with a fluoroscopy, or you can do it with the navigation system. I had trained with navigation all through training, so 7 years of that in my residency, and then I went to do my fellowship, and they had one navigation platform that nobody ever used. They all did fluoroscopy, and I'm sure my hand is in a lot of fluoro and X-rays at the Cleveland Clinic, which I did not like radiation exposure. So I'm probably in a lot of patient X-rays with my hand, with the gear shift going down and putting pedicle screws. But I think that we had a navigation platform. It's interesting. It was in the hallway, and one of the older guys who was probably like 2 years away from retiring, I was like, why don't we try the navigation system for this instead of doing all this, standard fluoroscopy and all this radiation exposure? He's like, well, if you know how to use it, let's try it. I said, great. I brought it in with the radiation technologist, and we used it. And it's so funny, like the light bulb went off in his head. He was just like, this is the coolest thing ever. And I'm like, yeah, this is the coolest thing ever. Like, why would we not want to use this? And I don't know. Nobody ever really showed him it is a problem. So I think we have just in our minds as surgeons in general, we like to do things the way we've always been taught to do it. Like we don't adapt. I talked about adaptability. Like I've been doing it this way. I do it great. I do it fine. And I'm not going to change. It's hard to get a surgeon. We're all sort of cut from the same cloth. Like we sit in the same chair in class. We like to do things the way we like to do it. So, you have to step out of your comfort zone a little bit to get and sort of adapt. And so to me, it was embracing technology. So I love the navigation platforms. We had those at the hospitals, but some of the things I absolutely love using now is robotics. That's a new technology that came out. I was at a conference and they were unveiling the first robot publicly. And I can tell you that I was the guy teaching the navigation platform. And all the people that were there, I thought, oh, this is cool technology to show people, but nobody was there to see that. Everybody was there for the unveiling of the robot. And I just like watched all this fascination from all these surgeons. I was like, that's the future, because I just watched people doing this. And so immediately I was like, we need to acquire this technology. And I haven't looked back. I mean, there's definitely a learning curve to it, but it has been awesome. I just did my 400th case this last week. So just, it's been great. I've been kind of rising my surgical procedures with the technology itself, because we've only had it for a couple of years in terms of the platform. And so some of the things that we've been doing with the robot hasn't even been developed yet. So we've been been nice as part of the advisory and development team to actually be on, again, the cutting edge of that.
So the way the room runs in a robotic case on case 400
Yeah.
is vastly different than
Yeah.
how it runs from cases 0 to, I'll even say, 50.
Yeah.
Tell me about that learning curve, the
Yep.
adoption, even some of the headache behind adopting a success, or not adopting, building
Yeah.
a robotics program.
Yeah, I think that the most important thing that we learned, and it's interesting if you go back through the tech. So they actually monitor the data usage. How long does it take for the setup and doing all these? So we actually have a lot of metrics that we have followed over the last 400 cases. Because I think, again, if you're not trying to look back to see what you can change to make better, you're never going to make progress, right? You have to reevaluate constantly. So when we first wanted to use the robot, it's interesting. They asked me like, who's going to mentor me through these cases? And I was like, well, nobody, because nobody knows how to use this. So we had to sort of do a dry run. We had a case scheduled on Monday. We brought in burritos on Sunday night. We ran essentially through a dry run through the case. Where are we going to set the robot up? Where are we going to set the navigation system? How is a patient going to be placed in the table in the OR room so we can bring the system in? But we sort of did the dry run to make sure that it was smooth the following day. And I think that was really important to the success of the first case. When we look back at the time that it took us to add to a case, it was about 47 minutes. Not too bad. So about an extra hour for the first case. If we look at the next 100 cases, we had brought that time down to about 37 minutes. So about 10 minutes saving time. We can now do robotics in about 12 minutes. And that's after the last 100 cases now, if we look back at the data. So you talk about it, but you have to have a dedicated team that's willing to learn and do that, right? So we have technologists that know how to use the machine. We have there's only 3 scrub techs that know how to use it. Everybody else doesn't really know how to. They want to come in my room, they have to know it. But I think this is true for any robotics program. You can talk about Mako, you can talk about Da Vinci, so we can model this after any robotics program. But I think the key is having people that are sort of bought into it. And in terms of the data, it shows that you need about 10 to 20 cases, robotic cases, before people come proficient with it.
And to be fair, the one key point that you hit on was the staff in the room.
Yeah.
Same staff.
Critical.
Yeah, you have to have a staff that's all on board and understands how to run the robot.
Yep.
Where I've seen the robot programs fail miserably. I would say more often than not, I see the robot programs fail, not because of the technology, but because of the implementation. I look at the turnover in hospitals. I'm looking mainly at South Denver, right? From my small clip of the world. The turnover of staff in hospitals is a problem. It's been horrible. They're short-staffed.
Yeah.
We never have the same person in the room. There's something after COVID, and I'm sure there's a bunch of factors to it, that have made those jobs that are oh so critical to successful surgery in high demand, but low paying still. And I think that's probably, I'm sure that's a much larger conversation around that. But how were you able to keep the same staff in the room?
Yeah. Well, I think that, again, if a hospital is going to invest that much, then you have to talk to them. So first of all, to get a hospital to buy into a system, it's not like the olden days. You know how it used to be. Oh, I want to use this system, and they're like, sure, no problem, bring it in. That's long gone, right? You have to show value proposition, and you know that. What's the value proposition of what you are proposing for us to bring into the hospital? It's a giant capital investment for anything, a navigation platform, robotics platform, as you know. When I was looking at the platforms, I had taken the charge of the OR nurse, and I took the person that writes the checkbook. We went and evaluated the systems together. So I always tell people, this is not a me against you. This is us together. We're going to try to decide how we're going to do this and move forward. First of all, we have to have buy-in from the hospital to say, we're going to do this. And that was the great thing about it. When they went and saw these platforms, they're like, this is pretty cool stuff, right? So now all of a sudden, the person who's in charge of the OR is excited about it. The person who's going to write the checkbooks excited about it. So it's not like, oh, geez, we got to write a giant checkbook for a very expensive piece of equipment that the surgeon wants, right? That essentially creates a, them versus you situation. You don't want to do this. You want to sort of do this, right? It's got to be a partnership. Once they've said, okay, we're going to do this. Okay, guys, if you're going to invest this much capital, what I want you to do is we want to have, so at that time it was Mako and Da Vinci. They had specific teams that only worked in those ORs. If we're going to have a spine robotics program, we need to do the same thing. We need to replicate and duplicate that. That was an important part of the purchase from the hospital, not with the company. We're going to train 3, surgical techs who know how to do this. We're going to train 3 radiology techs that know how to run the machine, right? We're going to make sure the company sends us people that know how to use the machine. So again, we're not just going to go in there and like Sally G, who's a traveler, 2:00 in the morning is going to come in and start running this machine. And like, I don't know what's going on. That you already said it. It's an instantaneous failure, right? So I think from the beginning investment all the way through the end, you have to set the expectations that we are going to do this and we're going to do this as a team to make the program successful.
How much did your leverage play in that you were a private practice surgeon? So like you could move your cases anywhere you wanted to take them.
Yeah.
That had to have been a factor. In my experience with hospitals, they're usually moved, at least right now, by the stick more than the carrot.
Yeah.
So if you could, or maybe it's a bigger carrot, I don't know, that you could be able to bring your cases there, or that you would take your cases from there. Was that a part of the negotiation?
It was, of course, at that time. And at that time, I'm currently a hospital employee, but at that time, we were covering 5 hospitals. So I literally went to all the administrators and I asked them who wanted to help develop a program. So it was really, the ball was in their court. And if they were like, no, I said, okay, I'm talking to your friends or your enemies, whatever you want to call them. If you don't want to do it, I'm going to go to the next hospital. So those conversations definitely happen, and everybody wants to keep up with the Joneses. So I did find a partner. We had 2 or 3 partners that wanted to do it, but the question was who was really going to invest A to B, not just like buy the platform. I did not want that. As you alluded to, it is a failure, fall flat on your face right away. Who's going to invest the time, energy, and do the marketing and make sure this is a successful program?
It's funny because I'm friends with a lot of our competitors, right? A lot of the
Yeah.
competitive reps and everything. And it's interesting to see one of the best sales guys I've ever met is the guy that sells the Excelsior robot for Globus,
Yep.
right? Really good sales guy, has seen a lot of those input. And I was asking him one day just in the hospital, I'm like, do you guys still sell on the idea that robotics is marketable? And he goes, we had to abandon that. I go, why?
Hmm.
And he's like, no one will invest in the marketing for it. He's like, they don't invest in the marketing. He's like, so it's what we have to do is legitimately partner with the right physicians like yourself that are forward thinking
Yeah.
and can actually move the needle.
Yeah.
But it was interesting to hear him say that. He's like, we started out that way.
Yeah.
That's the way the Da Vinci started out,
Yeah.
right? They would. I'm good buddies with one of their first reps, and he was like, yeah, it was what we would do is we would buy a billboard equidistance from 2 hospitals, and we would say, hey, there's a system on a truck coming here. It's going to be here in a week, and that billboard's going to have the picture of that robot on it.
Yeah.
Which hospital are we going to put on that as well?
Yeah.
And that's how they did it.
Yeah. Yeah, that's absolutely the right. I mean, exactly right. That's the whole thing, and I think that's kind of the point. But I think we did have the nice thing about being in the Boulder community. I think in Colorado in general, we have a very educated population. They will do their research, so it's not just people walking in willy nilly. They will ask you like, "Hey, do you do robotic surgery?" Because they hear about it from the Da Vinci, they hear about it from the Mako. So they are asking us like, "Hey, do you do this?" And now they know we have a spine robot. So I do think we have also some forward-thinking patients. People get
100%.
first opinions, second opinions. So if you're not doing it, you kind of get the sense like I should probably do it. That's how I feel. And my partner may disagree.
I'm a marketing firm, so
Yeah.
I'm going to be right there with it. I'm like my customer are surgeons trying
Yeah.
to get patients, and
Yeah.
I will always tell them they are better off outsourcing their marketing to a marketing company
Yeah.
than to necessarily only hire in-house
Yeah.
marketing because it's such a lift. I mean, now it's important to post every single day on social media. It's important. It sounds dumb,
Yeah.
but
No, I got you.
it's my parents are scrolling constantly, which is crazy to me. They scroll
Wow.
more than I do, right?
Wow.
And they're of age that are getting operated on.
Yeah.
So it's really interesting to see the marketing component of it. Tell me about your partnerships with companies. Like,
Yeah.
how do you navigate as a surgeon?
Yeah.
Which company to use, which rep to use?
Yeah.
How do you make that decision? 'Cause there's a lot of noise around that.
Yeah. I mean, when I first started out, first of all, you almost do what your partners tell you to do. Again, when you're brand new and green, you're like, what am I supposed to use for hardware? They're like, rotate through everybody. So we literally had a Rolodex. And I mean, you and I never worked together directly, but I used all of the companies. Every case was a different company. And I think probably what you end up learning, as you know, is it's very difficult for the scrub techs and people in the room to run a case smooth because it's like, who are we using today and what system? And they're similar, but there's nuances to all of them. As you know, are you breaking the cap off or just tightening it? All these kinds of things are nuances that to me are just not efficient. So over time, kind of sort of migrated to 1 or 2 companies just because I think it becomes more familiar. Again, we talked about like we did a dry run with a robotic platform once, and we can replicate that. We don't have to every time then the rep, and I think the reps do an amazing job. It's not a cut to you at all, but sometimes the reps like, I didn't know what size cages you want, so they didn't have the right sizes there. So sometimes you fall flat on your face and you're having to pivot and say, okay, what are we going to do now? And ultimately, there's a patient on the table. We're always doing safe surgery, nothing about that, but you're always like, you don't want those kinds of situations, the situation. So I think dialing it into 1 or 2 people that you're accustomed to, platforms that you're accustomed to me just takes a lot of the headache out. So I just, again, I'm getting old and wise, and I think that that's probably the way to go.
I agree. And it's interesting too, because when you started, there were really only 4 or 5 companies, right?
Yeah, I would agree with you. Yeah. Mostly that we used. Yeah.
Right. And
Yeah.
pricing on pedicle screws were really high then,
Yeah.
right? It was high.
Yeah.
So is what that allowed is, you could cycle through those 4 or 5 companies. Same rep would be there.
Yeah.
But ultimately still was more efficient to have just the one rep that you knew. and maybe the one company. Now there's over 250 companies that make pedicle screws. I think Advent has a preferred vendor list of like 10 vendors.
Almost like 6 actually with the carve outs.
Yeah.
Yeah.
Yeah. Almost.
Small.
Yeah. And then you have all the small carve outs that are
Yeah.
really niche, which
Yeah.
is great. I want there to be competition. I
Yeah.
want there to be,
Yeah.
but the other problem is the pricing of the pedicle screw and the implants have come down so far
Yeah.
that the other thing you have to think about is the rep I'm using have enough business to keep everything in town and at every hospital at all times?
Yeah.
And it's a whole nother algorithm with that. It's interesting. These hospitals will cut the pricing of implants and not realize that they're actually going to be cut their accessibility to those implants as well.
Yeah.
So that's a whole nother balance to think about and figure out as well. But I couldn't agree more. There aren't very many surgeons we work with where we don't cover at least 75% of their cases.
Yeah.
For the same reason that you're saying, is because it's consistency. You
Yeah.
know, even though our model's different in that we have any given case, we probably have 5 different companies in there.
Yeah.
Right. But it's all the same because we've done the same thing over and over again with the same surgeon.
Yeah.
So the surgeon doesn't know any difference. They'll just put our distributorship name down, and then
Right.
that's what they know.
But at least the person is consistent. That's the difference also. 2:00 in the morning at a trauma. And if you've been using somebody different every case, the nurse in charge is like, which company are we using? It's 2:00 in the morning. And you're like, whatever we have, this is an emergency. So you could fall flat on your face if you kind of play that game a little bit. So, but it is nice to have a consistent, like, hey, call Chandler. He's going to be covering this case. Then it doesn't matter what the system is. That you have the stuff there.
Well, it is funny too, because whenever we hire new reps, we're like, you are going to learn about pathology. You're not going to learn about systems. You're not going to learn, about C-spines, pedicle screw. You're not going to learn about Zavation's pedicle screw. You're not going to learn about Stryker's pedicle screw. You're going to learn the pathology.
Yeah.
So when, to your credit, at 2 a.m., if I get a text and it just is a picture of, some type of burst fracture from, Dr. whoever, I know exactly we're speaking the same language. I'm like, okay, this is what we need there.
Yep.
Based on what we've done.
Yes.
So many times over.
Yeah. 100%.
I really think a lot of that relationship of that tight relationship between the surgeon and the rep, I actually think it was solidified during COVID.
Yeah.
I think that was a heavy solidification period because your resources are much more limited.
Yeah.
Every company scaled back their reps to where there weren't as many options.
Yeah, that's true.
So it was like, all right, what do we do? you
Yeah.
know?
Yeah.
And that was kind of the litmus test, and that was built on the trust of everything that happened before COVID.
Yeah.
And that was just kind of my understanding of it. Tell me a little bit about, we were talking about before the podcast, we were talking about surgeon preservation.
Oh, yeah. Yes.
Really interesting topic
Yeah.
that no one talks about.
Yeah.
You are particularly passionate about surgeon preservation.
Yeah.
Tell me about surgeon preservation.
Yeah, it's kind of a term that I heard once, and I've kind of tried to coin it myself. So, it's interesting. We talk about the challenges we face in healthcare, and surgeon preservation sort of came to me because I went and experienced myself as a surgeon several years ago. Like any surgeon, started developing a little bit of tingling numbness in my right hand, and like any surgeon would do, or anybody, we just ignore our symptoms, kind of just keep on going. And I was a very busy surgeon. A lot of spine surgery, was hitting crazy volumes of surgeries. I'd hit the most 474 one year. So like just insane volumes because I was just doing whatever. Started to develop some tingling in my hand, and I knew as a surgeon this was probably a little bit of carpal tunnel syndrome and whatever, no big deal. I got myself a wrist brace like I normally treat people and things like that, and just ignored my symptoms and continued going on. So this went on for like a couple weeks. Symptoms got worse, so I called up my sports medicine doctor, and he got me an EMG, and we looked at it, and he told me I had grade 3 carpal tunnel syndrome. Essentially, that's a moderate, so there's a little bit of sensory deficit in my hand. And I was like, well, what do you think I should do? And he's like, well, you should go see the hand surgeon if I get this taken care of. And of course, like anybody else, again, in healthcare, I completely ignored it. So a couple weeks go by, I'm continuing to operate, and it's very vivid to me. Like a Monday morning, just made an incision on a case I was going to be doing for like 6 or 7 hours, big deformity case. And my hand went completely numb. And I don't know if you ever had this sensation before, but it is the weirdest thing ever. Couldn't feel my hand. So I had normal motor function, but when you can't feel and there's no tactile feedback, I didn't know how much pressure to apply to a scalpel, to a bovie, or even just like in my gloves. So kind of had a freak out moment. I knew I wasn't having a stroke. It's just my hand was numb from the tunnel. So waited for like 45 minutes. Something didn't come back. Talked to my head nurse, talked to my OR director. I was like, what am I supposed to do? And they're like, well, what do you think you should do? And I'm like, well, the right answer here is to close up and finish up. And I talked to the patient's family. They're very understanding. We closed up with the PA. I went and saw my hand surgeon, and it was 9:30 in the morning. Went to his office, and he's like, "Yeah, your carpal tunnel is just surgery, like we told you weeks ago." And I said, "Well, when can you do this?" And by 4:30 that afternoon, I had an endoscopic decompression of my right hand. It went great, but that was kind of an eye-opening experience for me personally, because I was kind of like, "Gosh, we're essentially taught to beat ourselves down, like you're not tough enough." And what happened to you? I started doing a little bit of research into sort of like this concept of like injury to surgeons, and found that it's actually much more prevalent than we talk about. Again, it's kind of like something we just sweep under the rug. We don't like to talk about, when people are injured, especially as surgeons and doctors. And so this concept of surgeon preservation came up to me because I think it's more about letting not just surgeons know, but public know, people know in healthcare, like, hey, it's not just you. Actually, it's pretty prevalent numbers, and we can talk a little bit about the numbers that I found out when I started doing the research. So I've been giving talks about this very topic, trying to just sort of get some traction about making other surgeons understand. It's fascinating because just last week I was talking to another surgeon who just had carpal tunnel surgery as well. But I think the numbers and prevalence I see are right, because the more surgeons I talk to, they come to me and they're like, "Hey, by the way, I had shoulder surgery, elbow surgery, wrist surgery." So I think it's a reality.
And credit to you for making the right decision and closing up and not continuing with that surgery with that patient. But the amount of pressure around you on that
Yeah.
to do the surgery had to have been immense still.
Yeah. And I think that that's exactly the problem. The person I actually talked to last week called me on Monday and said, "Hey, I've been recommended carpal tunnel surgery. I'm so freaked out. I don't have time. I have cases booked up. And if I have carpal tunnel, I'm gonna have to move my 6 to 8 weeks worth of cases." And he goes, "What do you think I should do?" And I said, "Listen, I went through this very same dialogue in my own mind. I ignored the symptoms until it became an emergency. You can't just walk away and pretend it's not going to happen." So I think that's kind of the problem is it's primum non nocere is this concept of first do no harm, and this oath that we take to patients, like, oh, we have to dedicate everything we do to what we for our patient care, and that's perfectly fine. But what becomes secondary to that is ourselves. We don't take care of ourselves. So when you're standing there and you have a patient on the table who's got their whole life ready to go, you can't, and you're thinking about, do I have to even canceling one case, as is a hard decision for a surgeon. If you're going to have surgery, you're now having to cancel several weeks worth. And it's unfortunate for patients, but if you don't take care of yourself, there's a much larger implication there.
Absolutely. And the hard thing is no one's actually going to be looking out for you, right? As much as kind of going back to even you getting advancing technology for patient care in the hospital didn't do it out of the goodness of their heart, right?
No.
They weren't like, hey, I want to spend $1 million on this robot
Yeah.
and another $300,000 on support staff to help support that robot.
Yeah.
They did it because the dollar demanded it, right?
Yeah.
They wanted your cases there.
Yeah.
Likewise, they probably don't want you to have surgery sometimes. They don't want
Yeah.
you to push cases out 6 to 8 weeks.
No, and I'll be honest, everybody's been very supportive of it. And I think that's what's interesting is like some of the data I found out about is if you look at it statistically, 59 to 99% of surgeons are unaware of hospital resources. Okay. So there are hospital
Wow.
resources.
Wow.
33% of surgeons don't seek any help from their hospital when they have these things. And the same thing for me. I just caught it and was like, oh geez, I have carpal tunnel. Like I'm just going to deal with it. If you look at OSHA and all these workplace injury sort of standards that we have out there, that's for anybody that works in a workplace. So these are actually standards that are held for everybody, including yourself, no matter where you go. But as surgeons, we just feel like, oh, geez, I don't fall into these spaces. We actually do fall into these spaces. We're just so embarrassed to talk about it.
That's so ironic because you have to always bring people past the embarrassment and shame of injury or maybe uh, uh, self-delayed care and have to bring them past that shame point, but you yourselves are embarrassed by it.
Right. Yeah,
Um,
exactly.
so kind of run through some of those stats with me on
Yeah.
what in your time of researching this,
Yeah.
what are some of the common injuries? What are the rates of injury to surgeons?
Yeah, it's fascinating. So when I started sort of going down the rabbit hole of all this, there was interesting studies. So I now primarily do spine surgery. There was a 2020 study of NASA spine surgeons that asked, how many people had suffered from psychological, physical, all these kind of social, essentially injuries, call it injuries in general. And 80% of them had answered yes. That's an alarming statistic. That's almost everybody. I mean, 80% is very high. Back in 2012, they did a study of the Scoliosis Research Society, so SRS, again, spine surgeons who do deformity surgeries, things like that. They asked them about the types of pain and things that they suffer from. 67% back pain. There's 30 to 40 to 50% people with arm pain, hand pain, shoulder pain, knee pain, back pain, hip pain. Like all the things that we talk about from long hours of standing and working and torquing on extremities and things like that and backs. These are to me alarming statistics. If you look at the rate of surgery, so number one is like the rate of injury, and then we talk about the rate of surgery that surgeons have. In the cervical spine, it's about 4.6% rate of surgery. In the lumbar spine, it's about 7%. And we can say that those numbers are relatively low. But if you look at the demographics of the population, those are much higher than the average population. So again, we're having surgery done on us at higher rates than the average population. We're having 80% of people complaining about these things. So this is not a statistic that's like a one-off. That's what I felt. That was a one-off. And then I start finding out from other people like, hey, by the way, like you look around, you're like, I had carpal tunnel. Like it's kind of like the secret society, like, show me your scar, show me your scar.
Yeah. What's even scarier about those statistics that you just said is that, yes, the operative rate is higher than the general public.
Yeah.
The injury rate is way higher than the general public.
Yeah.
So to correlate those two, there are a lot of surgeons that are operating while injured.
That's 100%, I think, what we're trying to say. We just continue to neglect ourselves until it becomes a point of, so rather than doing sort of, we talk about surgeon preservation, that's kind of what I'm talking about, the concept. It's like when you start having a little bit of symptoms, we don't stop and say, okay, I'm going to do a little bit of self-care. And I know that we're doing a bigger movement with that, right? Wellness in the hospitals, that's really picked up, which is great. But the reality is, like, when people start having symptoms, now we're like, okay, I'm going to go to physical therapy and let me go see the spine guy. We're like, oh, my back hurts at the end of a case. And like, we just go back the next day and we do it again, like we just neglect it.
Yeah. And have you done any research on the mental health side of it as well?
I have not. They had sort of lumped all of that together, the psychological well-being as well. So I have not dove into that side of it. I'm sure that there's probably a lot of statistics around that as well. I mean, there's high suicide rate among doctors in general,
For
if you
sure.
look at it. So I think probably the answer would be the rates are probably alarming.
It's interesting from the outside watching private practice physicians go and do these surgeries that the hospitals want them to do. But then if there's ever an issue with that surgery or, a complication, which you're going to have, if you do surgery, you're going to have complications.
Yeah.
Immediately I've seen the hospitals turn around and just demonize it. And I'm like,
Oh, really? Wow.
we've
Jeez.
seen that quite a bit. Yeah.
Okay. Wow.
Again, there's also some too that like,
Yeah.
you have some surgeries that maybe shouldn't have been done or should, whatever.
Yeah.
But I look at the pressure and I'm like, man, you guys take on so much risk
Yeah.
and partake in so little of the profit, not profit in terms of just financial profit,
Yeah.
but profit in terms of recognition, in terms of being able to choose what you use in a facility, even,
Yeah.
right? Like it's a huge inequity
Yeah.
for what your demand is and what you actually get out of it and what you're enabled to do your job.
Yeah.
Tell me a little bit about like the transition from private practice to hospital employee.
That's a great question. It's so funny. I think social media is a tricky place to be, right? Because you kind of get curated information and depends where you are, I think. And so it's funny. When we dissolved our practice for no reason other than the fact that we just had difficulty covering hospitals, I think the sort of the nature of the beast is everybody wants to be a level 2 hospital, which means that we have increased demands of our physicians, in my opinion. We have not enough physicians go around to cover all these emergency rooms. So when my group disbanded, we were looking at sort of what are the next models. It's funny how demonized, you use the word demonized, I like that word, because we were looking at becoming hospital employed surgeons. And if you go out there and start talking to people, it is like selling your soul to the devil. Like, oh my gosh, you can't become hospital employed. And you're like, why? What's so bad about it? Like, tell me all the negative things about it. And you go down and start reading in social media, like, oh, we're losing independence as doctors. And I agree with all that concept of it, but it's like, geez, we just can't be hospital employed. I'm like, what's wrong with being hospital employed? And you hear all these negative things. I was in private practice. It was great, but I will tell you that the pressures of running a private practice that and read and see it, right? Reimbursement is going down. especially during COVID, we got hit hard. Nobody's paying my check if I'm not operating. There's nobody like watching over me. I am private practice. So if I don't operate, I don't get paid. I don't have a healthcare system just saying, oh, okay, we've shut down all the hospitals here. We're going to go ahead and just give you checks like everybody was getting. I know there was some, government assistance for a lot of people that were in practice. And we got some of that because that's what everybody applied for. Because without it, we would have sank, right? Like 2 years of no practice. We didn't fire a single employee. So we were paying full salaries for all of our employees throughout the entire. And we had about 35 employees and our volume was diminished. Actually, I can say that my volume was actually pretty up because everything that came in through the emergency department was operative. You couldn't send somebody for getting injections and physical therapy because there was nowhere to go. So somebody came in with a hot disc. You want surgery or you want to go home because it's COVID. So we actually ended up doing a lot of surgery, probably a little bit more aggressively just because of where we were at that time, right? Reflecting back, there was not a lot of conservative management you could do in COVID. That being said, when I looked at my colleagues that were working at universities or hospital employed, they're like, yeah, I haven't set foot in the hospital. I got to come in and do my 1 week at call and I'm getting paid every week. I'm like, man, that's a pretty nice gig. Like you got the monster of the healthcare system behind your back during these really tumultuous times. I've been employed now for 3 years and I can say it's been fantastic. And I think one is having sort of the security of a healthcare system. I know it's different than private practice, but I think that the other thing is that we don't have to worry about the day-to-day ins and outs of running a practice. Those are the things when you're in private practice, you're the HR, you're the CEO, you got to do the contract negotiations, you got to do all of that stuff. And that stuff eats up time. At 5 o'clock, you're sitting down to have dinner with your family, and Sally and Jenny were fighting in the back room because somebody said something that was offensive. Okay, we got to have an emergency HR meeting with the partners and talk about that stuff. That stuff will drive you crazy. Being employed, I get to just, focus on my practice, take care of good patients, and, they help with marketing. They do all the contracting, all that stuff doesn't make a difference to me. So I actually think to me, it's been a wonderful thing. Time will tell, but I think it's been demonized to a degree. And if you actually talk to people that have relatively good situations, they're like, life's pretty good being employed. It also forced me to slow down. I was probably working 6 to 7 days a week. I was doing everything. Our work days are typically about 4 days with an administrative day.
So in transitioning from successful private practice
Yeah.
to a great situation as hospital employed,
Yeah.
would you say that your experience in private practice and building a private practice is what enabled you to negotiate a better deal for hospital employed?
Yeah, I think that the important thing that we talk about, even with new hires, right? We talked about new hires is you really have to know your value. And I think we don't know our value. We are the ones that drive. Like we bring in the most money generally for spine surgeons, neurosurgeons. At the university, it was transplant, ortho, and neuro. Like you're one of the highest income generators for the hospital. Yet we don't behave that way. It's like when it comes to the contract negotiations, you're like, I'm not sure I should be asking for that because I want to get this job. It's like, well, be confident, hey, this is kind of what I want, negotiate. I'm not saying you have to kind of be a jerk about it, but I think that in private practice, we learn that. And my senior partner always said everything is negotiable. I always remember that. Part of that success coming into negotiating contracts for being employed. Absolutely. I kind of knew my value. I knew my worth. And I knew what I wanted. We're going to develop a program here, and this is how we're going to do it. So, can you offer this or not? And we shop around. I think it's the same idea. Who's gonna actually decide to take you on?
But to be able to shop around, it's interesting because I agree with you. Like where you landed and what you negotiated is fantastic. What it sounds like from just being a human, right? Like
Yeah.
you're not working 6, 7 days a week.
Yeah.
But it seems like it was really a deal built on your understanding of the market from your private practice.
Yeah.
So what would you say to guys that come out of training that are deciding to go hospital employed from day one?
Yeah. I think you have to really do your homework and do your research. It's the same concept comes when we talked about interviewing the surgeon, then you got to interview the family. Like the administration's going to tell you all these great things about the job. I think what you want to do is be like, hey, can you give me the phone number of maybe some of the surgeons that work here? Can I talk to some of the nurses? Can I talk to the OR director? Can I talk to the scrub tech? Hey, how bad is call? How many times do you end up coming in here? Are the surgeons happy? How many times is the equipment dirty? Go talk to the marketing department. Do they really market the surgeons or do they say they'll market and they don't market? So I think it sounds silly, but it's like If you're going to marry somebody, you date them before you jump in. This is no different. You talked about the failure rate and moving on. Our divorce rate is ridiculously high. It's the same concept. You're talking about divorces, right? People come in for a job and they leave. That's a divorce essentially. So I think that you have to, as a new grad, whatever it is, if you're looking at a new job, do your research. Don't be afraid to ask questions, but don't just talk to the administration. Dig around a little bit, kick the tires, look under the hood, and ask for some numbers. And if surgeon left and you're filling that spot, call that surgeon up and be like, "Hey, what happened? Why'd you leave? What's the true story?" And find out what. There's no reason why you can't get references and find that. So I just don't feel like people necessarily do that. I don't know, but I feel like people don't really do their research.
I, I think a lot of the training institutions, so like Cleveland Clinic,
Yeah,
how many of the Cleveland Clinic surgeons were private practice or
yeah,
were outside of academia? I mean, I don't know,
yeah,
but I'm not sure they would even know how to counsel someone in
yeah,
what to look for.
yeah,
Um, are there any resources anywhere online of like, hey, I'm a new surgeon, I'm coming out of training.
yeah.
How do I ensure that I'm finding the right job?
I mean, I think that nowadays you can find anything on social media. I mean, that's kind of the thing. Now you just have to do some factual checks with that stuff, but you can type it and say, "Hey, what are great questions to ask for a neurosurgery resident for a job?" I think, but the thing that I did also, you asked me about what was the success of finding this job out here. I reached out to my chief residents, so the people that were 6, 7 years in practice. Again, I did a ton of research. I called them up. Hey, when you interviewed, what were the questions you asked? What's important? You've been in practice. Tell me, what do I need to know? So I asked the people that had experience. The same thing if somebody asked me, I've been in practice for 15 years. We're having this conversation now. Can you tell me a little bit about what somebody should be asking as a new grad? We have so much information that we can get from just the people we train with. I mean, there were 7 of us per year. I mean, think about the lineage 7 years above and 7 years below me of people that I know. It's 14 people stacked and probably 1 to 2 each year. So that's like almost 20 people you can just ask questions to, and the faculty that you're working with and people that you meet at meetings. I can ask you, "Hey, tell me about the South Denver market." And you probably know the ins and outs of all of that stuff. I think the reps know a lot of stuff too. So I think, again, picking up the phone and calling people, not a hard thing to do. Just do it.
Yeah. Yeah. No, absolutely. It's funny how much I'll have new surgeons that work with us. If they're hiring other surgeons, a lot of times they'll actually direct them to talk to us
Yeah.
and be like, talk to these guys.
Yeah.
Like, you're looking at all these other opportunities. They work with most of those opportunities or
Yeah.
someone in those practices.
Yeah.
Talk to them about it. Get perspective. So I like your due diligence is spot on for it.
But I didn't even mention that, but I guess 100% the reps, they know all of the ins and outs and will tell you what's going on, right? A guy like you knows exactly what's going on in the OR and day-to-day basis and what's the trauma like. So I think the rep to rep, like, "Hey, Shannon, I'm moving to Tennessee. Can you get me in contact with the rep, or can you find out anything about this job?" And you'll come back and be like, "Not a good idea," or "That's a fantastic job. The guy had to leave for family reasons," right? I mean, you guys know all of the details,
It's
the dirty secrets, as we should call it.
it's funny. My uncle's a orthopedic surgeon in Denver, right?
Oh,
And I don't cover anything of his, right? He doesn't do anything in spine. I don't cover any of that. But when he was looking at moving, he was in practice for like 15 years somewhere else and then moved to Denver. He asked me about it. And that was the first time. And I was still like maybe 3 years into spine. I'm like, this is weird. He's asking me about this. Like, yeah, but I guess I know the guy you might join. I know.
yeah,
So it was really interesting seeing that for the first time, even back then.
yeah,
And now it's like, man, leverage whatever you can to get the information you can.
yeah,
Especially how someone acts in the OR. Like, how is this prospective partner in the OR?
yeah,
Like, do they have a plan moving forward? Do they have good outcomes?
yeah,
Right. We have a little bit unique of a situation because we do so many patient testimonials and like record so much stuff around that patient and that event.
yeah,
Following up, we get a pretty good viewpoint of how the outcomes are, you know.
yeah.
So it's a completely different, I guess, perspective of it, but it still is something that's definitely important going into a market.
It's a great perspective.
Yeah, yeah. So tell me something. What are you excited about in innovations in spine care coming up?
Everybody's excited about endoscopy. I'm going to probably go get trained on it in a couple of weeks. I just don't know. I don't know enough about it. But I think, the platforms and where we are, I think we're sort of at this inflection point where just like the technology is so cool. I mean, AI, we all know this. I mean, we use it like a buzzword everywhere, but how is it going to just transform what we do? We can do so much better with personalized care for the individual. Like if I look at you, we start to have now customized implants. We talk about all that kind of stuff. I use AI for my surgical cases as well. We talked a little bit about navigation. We made a leap to robotics. I'm now using AI platforms to help derive customized surgical plans for the individual. So you take a 40-year-old male who needs a one-level fusion, who has a grade 1 slip. What's the recommended surgery we should perform? It used to be, oh, we're just going to do a TLIF or we're going to do a decompression. There's all this debate about, statistics and numbers. What exactly does this individual need based on their spine, their symptoms, their age, bone density? What kind of implants should we be using? What kind of biologics should we be using? Like, we didn't do that stuff when I was training 20 years ago. We just did the surgery and slapped ourselves half five and said, it's great. Now we can see how much better we can do. I think just think of the personalized care that people are doing in general. Like people getting genetic testing and saying, oh, this is what I need. These are the peptides I need. And this, I'm low in, T and all these kinds of things that people have. Why are we not doing this when we take somebody and cut them open and put screws in their back or decompression? It's like we should be doing this so the outcome is like perfect. So I've been using the AI platform for about 2 years to customize my surgical plan for the patients. And I think that is really important. So we can also, reevaluate and see how we're doing for individuals.
I agree. It is really cool. And like it's interesting. You have a really unique ability now that you could use still the same rep in the room and to a degree still use multiple modalities,
Yeah.
multiple types of implants. Even when you talk about biologics, like the advancement in biologics
Oh.
has been insane.
Yeah.
We just, I absolutely love the Inspire study that Therapeutics did.
Yeah.
Phenomenal. I think it's the best biologic study I've ever seen.
Yeah.
But like even being able to have that and have access to that, huge for patients, even though they don't realize it.
Yeah.
It's really big.
Yeah.
For those cancer patients, those, the and again, I'm not a spokesperson for therapeutics or anything like that.
No, I was going to say specifically, I mean, what you're talking about is these ecosystems, right? People use the word ecosystems and platform. That's the whole thing. It's the pre to the intro to the post care. Like that's what we should be talking about. As surgeons, we're always worried about how am I going to execute this surgery, but we can do better with our planning. We can do better with our execution, and we can do better with our post-operative care. And it's sort of that 3-phase where we take the patient holistically and put it all together. And you're absolutely right. We can put it all together in the OR and say, hey, this is better for the patient with a better outcome. And that's essentially where we're going with all this. And that is what's so awesome about it.
So you think the evolution of spine care is makes a broader perspective of the patient as a whole?
Well, don't you think? I mean, I think the problem was if there's a grade 1 spondy on a patient, like let's just take one type of pathology, the way we would treat that is not necessarily the same between, let's say, a 70-year-old and a 35-year-old. We have devices that allow us to do decompressions in a more minimally invasive fashion. We have devices that don't just fuse, right? We have motion sparing devices. We have fusion devices. So now we can say, okay, here's several options for you. But now we can follow the data and say, oh, geez, we shouldn't have just decompressed. We should have done the fusion, or we should have done the motion preservation device. Let's go into our database and say, when we have all these 35-year-olds with this kind of pathology, this is probably what we should do. We look at the lumbar lordosis, the PI, all these kinds of things. We say, this is the specific surgery we should be doing for this patient. And it's customized to the individual rather than just, oh, I always do decompressions or I do endoscopic or I do a specific procedure. Like, no, what does the AI model tell us will have the best outcome for this patient? I think that's where we'll go because that's customized to you.
So it's funny, as a distributor, that is a lot of my pitch to these surgeons. When I left NuVasive, which I think is a fantastic company.
Yeah.
And I went distributor and like flew around, met with all these companies and then put together everything to make a bag across. I think we carry 53 companies now.
Yeah.
The biggest thing that my surgeons 2 years out is they said, I can customize the surgery to the patient and I don't have to fit the patient into the surgery.
Exactly.
And exact same thing you're talking about. All right, this person's, 70 years old, maybe has some osteopenia, but we need to do something.
Yeah.
We're not going to use the solid titanium in inner body. We're going to use maybe a tie-coated peak or something like that. Right. But I 100% agree that right now spine surgery has a window where it can really expand its perspective of the overall patient care. And it's interesting. The innovation is a race between innovation price, right?
Yeah.
Like that's the balance is how do you create a better widget? Because if you have unlimited price point, you could create the best widgets ever.
Yep.
But how do you do it to where it's affordable?
Yeah.
To where it fits within the pricing decreases that are going to happen every year for
Yeah.
both you and me,
Yeah.
to be fair. Um, how do you think GLP-1s fit into spine care?
Jeez, it's fascinating. It's interesting. I mean, I think we're actually having better. So we talk holistically about patients' number. So we're doing better about looking at bone health. We know that there's metrics that increase patients' risks of complications, right? Diabetes, obesity, nicotine use, things like that. So again, when a patient is signing up for surgery, we are making sure that we are reducing those risk factors for our patients. So again, trying to ensure that we have success. The obesity epidemic is real, right? This keeps climbing. So now we have the GLP-1s, which is a fascinating topic because I think we're learning about the side effects. And I was just reading the title of one of the articles that said increased dysphagia rates in ACDF with GLP-1. Now, I have not read the study. I'm not advocating it, but what's fascinating is I think we're starting to slowly look at the complications of these products. We want it for people to lose weight, but I think we're starting to see like this may or may not be a great option for our patients. Is it creating increased rates of pseudoarthrosis? What are the other complications? So I don't have an opinion about it. I think it's TBD, but what do you think?
Oh man, not supposed to ask me that.
I have
So it's funny. I had a surgeon bring one study to me that showed a correlation between GLP-1s and decreased pseudo rates,
Oh, yeah.
right?
Yeah.
And it took into consideration and randomized out the lower BMI, right? So it wasn't that there was something in that study. It pointed to something chemically different about it. I also found studies that showed increase in subsidence,
Yeah.
which is an increase in pseudoarthrosis rates, right?
Yeah.
And that's largely because of something that everyone's feared is that you decrease the intake of food, you're also decreasing the intake of nutrition, and you're starting to have these
Yeah.
kind of like early onset osteoporotic patients. So you do a TLIF on them, it would subside.
Yeah.
So I think that it's the GLP-1s offer a unique ability for spine surgeons to have a tool for the right person.
100%. You said it well. That's just it.
But again, for the right person.
Yeah.
I it's interesting with GLP-1s. I know, we walk around the hospital, we see a ton of people that work in the hospital that've taken
Yeah.
and done wonders for.
Yeah.
It's really early with them. I'm curious how you preserve muscle with the GLP-1s. I think it has to be very intentional.
Yeah. That's just it. All these things. I mean, it's just the problem is we're marketing these drugs for everybody. It's like, you're watching anything on TV and it's like every other commercial is for these products and you just like order them. And I don't think we really understand. And that's a little bit of the danger of it. Like, oh, just talk to your doctor about these products or just order it. It's like, we know what the implications are of these products. I don't know, 5 years, 10 years. In spine surgery, it takes time to watch. Like, oh, you operate on something and you find it have subsidence. You're like, what's the thing that changed in this patient that I've been doing for the last 10 years? Is it the GLP-1? Is it the malnutrition that they're having? It's funny, we have our patients lose weight to a BMI 35 or less because that's sort of what the guidelines say. We have these patients lose weight, then they come in for their pre-op appointment, they see the nutritionist, and the nutritionist pings us and says, hey, this patient's had a lot of weight loss. They're malnourished and all these kind of like, no, that's an intentional weight loss, but now they have all these other problems from not taking proper nutrition for the last, several weeks. So there's complications to everything that we do, right? Side effects.
Yeah, no, absolutely. A question I always ask, kind of the last question is when you're deciding what to use as far as a company.
Yeah.
Is the decision more heavily weighed on the company or the rep representing the company?
That's not a fair question. That's a great question, but it's not a right question. I think that it's a combination of both. And when we always talk about the fact that the rep in the room is essentially your friend and you have to rely on them. When you're scrubbed into a case, I don't have the capability of going into the back sterile room to grab a screw or an interbody cage. I am 100% reliant upon the individual that's in the room with me. We're a family, and the number one person is the patient on the table. So it is really critical that the person that you're working with understands your workflow and understands what you need. Like you said, you see a picture of a burst fracture. I know what that guy needs. I know what the patient needs. I'm going to bring him in. But we also need a company, my opinion, that offers all of those solutions. That's just my opinion. I know you carry a bunch of different products, but the point is, I don't know sometimes what I'm going to need in that case. I don't know if I need an expandable cage or a static cage. Do I need a titanium? Do I need a peak? What do I need? Sometimes you need a little bit of background of of all those options. So we talked about sort of the whole care. To me, you talked about widgets. I think companies are looking at procedural solutions, ecosystems as well. Do we have AI? Do we have robotics? Do we have navigation? Do we have AR, VR? Like that's another side we didn't even talk about. Endoscopic. I mean, these are the grab bag of all the things that's going to be so cool for all of us. Who's going to offer all of these things? Because again, you and I talked about hospitals don't want to invest in all these individual platforms. They want to invest like this whole ecosystem where everything runs smoothly together. So I think for me, is everything going to run smooth? Like, is the navigation platform speaking to the robot? Or if one breaks down, are they going to point fingers and say, if that one's broken or that one's broken? I don't know. And nobody's taking responsibility. As we have a patient on the table, it doesn't matter. It's got to be smooth. So I think to answer your question, the person in the room is absolutely critical, just like your team is. I think the companies are essentially to what we do for our patients.
I couldn't agree
Yeah.
more. The idea of a unbroken ecosystem is something that we are ultimately only one company. Like we're legitimately, we carry a bunch of different companies, but we're ultimately kind of one company that from our distributorship side, it's not that much different than what you would see with someone that works directly for a company, right? They do same thing. They're like, as long as this works together, I totally see that.
Yeah. Well, let me ask you a question.
Oh no.
Since you asked me a last
Yeah.
question. You've been doing this for a long time. What are you most excited about in spine surgery?
Motion preservation and endoscopic. So we developed an endoscopic program that is not an endoscopic program for necessarily a hospital. It's an endoscopic program for the surgeon in how they can learn and reproducibly do that case, as well as identifying the right surgeons that want to do it, right? The disadvantage of endoscopic is the price point. The price of entry doesn't justify doing the case, right? If you build it out, if you use the CPT code for endoscopic, you would actually make less than just doing the decompression. Travesty. But the other side of that is it also protects the procedure because it is in the learning curve of that procedure can be dangerous, right? I don't want to be on the learning curve of it, but at the same time, the surgeon that's done 100 of them, that's what I want.
Yeah.
I've seen it firsthand, and it's very similar to. It's not that different. It's very similar to disc replacement. The reason I compare the two is because inevitably you are almost de-incentivized to do disc replacement from a financial perspective.
Yeah.
Endoscopic's the same thing. The learning curve's higher. There's a commitment required to doing it, and you need to have a community around you that helps guide you through it, where you can text someone the night before.
Yeah.
And so this was kind of how we set it up, specifically around how you train for endoscopic. The other side is you have to have the same system that is at the hospital, that's at the surgery center, that's everywhere else that you go.
Yeah.
And that's where I'm excited to see a couple different endoscopic companies really kind of pull ahead, just because they have the vision and the ability to be flexible in those ways.
Yeah.
The endoscopic going through the endoscopic training as a rep was so frustrating because there's nothing I can do to help you outside of giving you suggestions from other endoscopic cases.
Yeah.
But there's no objective objective data that I can see. So, right, if you're doing a lateral or an X-lift, I can look at the X-ray and be like, all right, this is what you need to do with your hand. This is where you need to look. This is what you should be feeling.
Yeah.
In endoscopic, it's not like that. I'm I'm a resource in terms of I'm going to bridge you to people that know more than you about it and have done more, and you're going to have to try to figure some of this out.
Yeah.
It's very much a self-driven learning process.
Interesting.
But yeah, we go to endoscopic labs probably once every other month.
Oh wow.
With just surgeons from all over the country.
Yeah.
Because it is from a rep perspective, it is not a great procedure, right? It's low price.
Yeah.
You're there for a long time. And there aren't any implants going in.
Yeah.
Right. But that's what I like. Honestly, that's what I like about being a distributor is that I'm able to be like, hey, this is interesting.
Yeah.
I think this is the future.
Yeah.
And we do well enough on our other stuff that we're happy to sit here and help support someone in this learning process.
Yeah.
So I'd say disc replacement, which I will unashamedly say that I think Sentinel has the best disc replacement right now. I mean, there are a lot of good ones. And honestly, per patient, the best disc replacement is the one that the surgeon's most comfortable using for that patient.
Yeah.
But I'm most excited about Sentinel, what they've come out with in the match the disc technology. To be fair, Mobi-C is great in people's hands too. So is Simplify. So is Prestige.
Yeah.
I'm excited about surgeons learning about those things
Good for you.
because that's what, as a patient, that's what I would want.
Yeah.
So yeah, endoscopic disc replacement, anything motion preservation, I'm interested in. And honestly, I think the deformity stuff's cool too. The stuff that's coming out with that.
Yeah.
I just don't want to be a deformity patient, so it's further away from me. I'm less excited about it.
Yeah. Cheers to that.
Yeah, but some of the deformity stuff's really cool. That some of these small companies are coming out with great deformity stuff that's integrating multiple platforms and really has some good legs to it. So no, that's a tough one to answer. But I'd say motion preservation.
You answered it very quickly though, to be fair.
yeah, endoscopic motion preservation.
Yeah.
I think is the most exciting thing from a distributor standpoint. But
Very cool.
Thanks for coming on.
Yeah.
I'm excited to see what you come out with, what else goes on. I follow you on LinkedIn and see some of the cool posts and whatnot. And yeah, we run in the same circle. So yeah, I'm excited to see where you guys go, man.
Appreciate the invitation. Thank you so much. This is great.